Coming to the diagnosis and management part of aspergillosis. So in the diagnosis part, we'll basically discuss about the diagnosis of acute invasive aspergillosis. As I told, chronic aspergillosis, the diagnosis is mostly based on the imaging findings and the antibody levels. And in allergic aspergillosis, I told about the criteria used in allergic bronchopulmonary aspergillosis. Here we will be discussing the diagnostic part of acute invasive aspergillosis. First thing is, what about blood culture? Blood culture is positive in only 10 to 30% cases of invasive aspergillosis. And you have to specifically send for fungal blood culture because bacterial blood culture is very less sensitive to diagnosis aspergillus to grow this aspergillus. And a positive blood culture may represent a simple colonization also. So blood culture, even if it is positive, can be either due to invasive aspergillosis or it can also be due to non-invasive forms of aspergillosis. You can do antigen detections or RT-PCRs, which are more sensitive for diagnosing this aspergillosis. Then there is a serum antigen marker, that is serum galactomannan, which is very commonly used in clinical practice as a marker of acute invasive aspergillosis. Now, the serum galactomannan, it is more sensitive in respiratory samples, more sensitive, more likely to come positive in respiratory samples than serum sample. Positive positive serum galactomannan. Usually precedes clinical bar radiological features. So a positive serum galactomannan may precede clinical bar radiological feature. So before the patient is symptomatic for aspergillosis or before the imaging could shows the findings of invasive aspergillosis, this serum galactomannan may come positive. That's why it has this test has gained a lot of popularity. And also the sensitivity of antigen detection sensitivity decreases with antifungal therapy. Antifungal therapy. Now, what about histopathological finding? If you do affected organ histopathology, you may get infarction due to I told because the aspergillus is angio-invasive, they can cause infection, necrosis. You can visualize invasion of blood vessels, and the fungal hyphae. This is important. The aspergillus fungal hyphae, they are narrow, they are septate, and branching at 45 degree. Branching at 45 degree. This point is important. If you see this image here, you can see the septate hyphae, the narrow septate hyphae with branching at 45 degree. This is aspergillus. This image is showing angioinvasion. Now the next thing is in HRCT, you may get a finding known as halo sign. Halo sign. What is halo sign? In halo sign, we'll have central hyperdensity and surrounded by a peripheral ground glassing. So this is peripheral ground glass opacity or ground glassing, and this is the central opacity. Okay, central opacity, hyperdense lesion. surrounded by a ground glass opacity. Now this central hypertense lesion this is due to consolidation. Is due to consolidation, and this ground glassing is due to the associated infarction. Associated infarction. This is known as halocene. This is a feature of angioinvasiveness of aspergillus. So in this image, you can see here. Here in the center, you can see there is a hypertense lesion or nodule, and it is surrounded by a ground glassing that is due to the infarction. Coming to the treatment part, we'll start with the treatment of invasive disease. The first one is treatment of invasive disease. The most important drug is voriconazole. Most important, the most commonly used drug for treatment is voriconazole. But apart from that, you can also use itraconazole and isavuconazole. Isavuconazole. Okay, so voriconazole, itraconazole, isavuconazole. Using voriconazole, it has shown 20% higher response, 20% higher response than amphotericin B, B. Now remember, amphotericin B is a second line agent for invasive aspergillosis. Other second line agents include caspofungin and micafungin. So caspo and micafungin. Okay, so voriconazole, isavuconazole, these are the front line or first line agent for invasive aspergillosis. This voriconazole has shown 20% higher responsiveness than amphotericin B, which is a second line agent. Okay. Next point is whenever you are using voriconazole, you have to do therapeutic drug monitoring because of high inter-individual variability. Therapeutic drug monitoring has to be done. And also azoles are CUIP 3A4 inhibitors. These are CUIP 3A4 inhibitors. So you have to always keep in mind the possibilities of drug interaction. Okay. Because all these patients, immunocompromised patients, they will be on various medications. So possibility of drug interaction has to be kept in mind whenever you are using voriconazole. Okay. So the dosing for voriconazole, if you're using IV, it is start with 6 mg per kg Q12 hourly. For day one, it is the loading dose, and followed by 4 mg per kg Q12 hourly. This is the usual adult dose. Okay, this is the usual adult dose. If you want to use orally, then after the loading dose, 200 mg BD has to be used. Okay. Now, one point about amphotericin B. Remember, amphotericin B is second line agent because it is 20% less responsive, and also amphotericin B is not effective. It is not effective again against Aspergillus teres and Aspergillus nodulans. Aspergillus teres and Aspergillus nodulans. Again, Aspergillus niger, it is resistant to itraconazole and isavuconazole. Resistant to itraconazole and isavuconazole. That's why the most important drug I told is voriconazole. Okay. So this is about the invasive aspergillosis. Now the one last point is regarding the duration of the treatment. The duration may vary from 3 months to 1 year. May vary from 3 months to 1 year, depending on the response to the therapy, and also depending on the degree of immunosuppression or the duration of immunosuppression that the patient is having. Now, if the patient has chronic 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 aspergillus disease, or chronic pulmonary aspergillosis, the drug that are effective are itraconazole and voriconazole, itraconazole and voriconazole. And here the duration of treatment may vary up to more than 6 months. More than 6 months. Then what about aspergilloma? Aspergilloma, as I have already told you, aspergilloma, if it is single, then you can just do surgery. You can just do surgery. If it is multiple, then surgery also doesn't have much role. You just give itraconazole therapy. You can just give itraconazole therapy. For ABPA or SAFS, the treatment of ABPA I have already discussed, and the treatment of SAFS is also same. And here the antifungal that we prefer is itraconazole. Here the antifungal that is preferred is itraconazole. The last one is prophylaxis. Prophylaxis. Remember the most common prophylaxis that is used in acute leukemia cases is fluconazole. But remember, fluconazole doesn't have activity against Aspergillus. So fluconazole, no activity against Aspergillus, no activity against Aspergillus. So the most effective drug for prophylaxis is posaconazole. Okay? So most important is posaconazole tablet or itraconazole solution. Okay, but if azoles are contraindicated, then you can use IV micafungin. You can use IV micafungin. Posaconazole is used 300 mg BD in day 1, followed by 300 OD. 300 mg OD. Okay, so this is all about the diagnosis and management part of aspergillosis.